These seizures, they can occur in two scenarios. The first is that the mother had been given very high doses of pyridoxine antenatally, and the child now becomes dependent on its metabolism for very, very high doses of pyridoxine. Upon being born, when the high doses are not being provided, the child starts throwing seizures. And these seizures can be managed with an interim high-dose pyridoxine for a couple of weeks until the child's threshold normalizes. The second case scenario is an autosomally recessive condition which is inherited inborn error of metabolism. In this, the child can start throwing seizures as early as intrauterine life. But most usually, these seizures begin a few hours after birth, but sometimes they can also happen after the neonatal period ends, in the post-neonatal period. Usually, these seizures are multifocal, clonic type of seizures. But sometimes even GTCS, which is a very, very rare entity in neonatal convulsions, but this can be found in pyridoxine-dependent seizures. So GTCS can also be seen. These seizures are associated with neonatal encephalopathy, which can be characterized by hyperalertness, irritability, tremors, emesis, which basically happen before the onset of seizures. These kids, they usually have recalcitrant seizures, which however can be maintained on monotherapy of pyridoxine. Sometimes it can happen that the child was initially responding on multiple anticonvulsants and later stops responding to them. So we should give a trial of pyridoxine in such patients. Whenever suspected, a therapeutic trial of mega doses of pyridoxine should be given. If at all an IV 50 to 100 mg of pyridoxine is able to abort a seizure, and this is one of the diagnostic aids that the seizure is pyridoxine dependent. But please note that cessation of seizure usually happens immediately. But EEG changes, they may take a while. They happen maybe after, they basically resolve after a few minutes, or sometimes they may take even a few hours after giving the dose. But seizure termination usually happens immediately, and therefore it is a diagnostic aid. If you look at this particular EEG, you'll notice that there is asymmetry. And there is also asynchrony in the background, which is suggestive of a disorganized background EEG. This disorganized background EEG, it later ends up throwing spikes and slow waves. So there is a generalized, in all the montages, we are seeing spikes, slow waves, sometimes sharps are also seen, polyspike pattern is seen. So this generalized abnormality, it was basically because of pyridoxine deficiency, dependency, and this EEG had normalized after a few minutes of giving pyridoxine IV 100 mg. And here we can see a normal sleep pattern of EEG. Now, why does it occur? It occurs because of defect in metabolism of lysine. This is a very important point, and it has been asked many times in SS entrance, that lysine metabolism is affected in case of pyridoxine-dependent seizures. What happens is that lysine metabolizes to form a product called alpha-aminoadipic semialdehyde. Let's call it alpha-ASA. This alpha-ASA is supposed to further metabolize or catabolize using this enzyme alpha-ASA dehydrogenase. In case of pyridoxine-dependent neonatal convulsions, this enzyme is deficient and therefore alpha-ASA accumulates. This accumulated alpha-ASA, basically it combines with PLP. It forms certain other compounds, and these other compounds, they combine with PLP and consume it, causing a deficiency or shortage of PLP. So this PLP is getting consumed because of these other products which have been formed in this particular condensation reaction. PLP gets consumed and we have a deficiency of PLP which happens. This PLP was required or needed in the synthesis of GABA, in absence of which we do not have GABA, right? So in absence of this PLP, which was primarily deficient because of absence of this enzyme, right? So in case of, when GABA deficiency develops, the child starts throwing seizures.